Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everybody. I am super excited to announce that we officially have our first sponsor for our podcast. And Sarah, Kelsey, and I are super excited because we haven't even released our podcast. So this is somebody who really believes in what we're doing. So this is Lever Movement Systems. And I'm also excited, which I've said 3 times already, but because I use this with my patients a lot. So this system is a body weight system where we can offload the body if somebody has a tendinopathy or a bone stress injury, or they're coming back to running postpartum. So there are a lot of different ways that we can use this system and that we use it in our clinic. And I really want you guys, if you've never checked them out before, I would love for you to check them out on levermovement.com, because they are believing in us and they're allowing us to bring these cases to you. And so because they're believing in us and allowing us to do what we love, I would love for you to support them. We are here tonight to record a new episode for everybody for our Interdisciplinary Case Miles, which I'm still excited about. And I wonder if every single episode I say this, but we'll see. But how are you guys doing?
Doing awesome. And actually, I mentioned that we were doing a podcast series to one of my patients who got very excited. So it got me very pumped about tonight, too.
Well, I'm good. How about you, Kelsey?
I'm doing good. I've personally been able to jump into some intensity in the last 2 weeks with my hamstring, with some of the advice you guys gave me when I was in Boston and we were all together.
Oh, I'm so glad to hear that, because it makes such a difference, doesn't it, when you can actually do what you want? I know.
Yes.
I'm so glad to hear it. Well, let's just jump into this case. I actually just got back from running camp. I do want to say that. And it was a kids running camp, so middle school and high school runners. And I still had a lot of fun, but I'm really tired tonight. So hopefully my 2 cups of coffee did help us out. Okay, so the case that we're going to talk about is, I'm going to talk about it first, and then we're going to go over it together and kind of talk about who would do what, and we'll ask each other questions so you guys have an understanding of how we would think through this and what we would do for somebody like this. But the case is a 26-year-old male, former collegiate athlete. He is a runner. And he started a new job about 5-ish months ago. He is doing trail races, trail running, sometimes just going out without a watch and running anywhere from 10 miles to maybe 20 or a little bit more at a time. He also is a cyclist, and he's just a general outdoor enthusiast. So he's moving his body a lot, hiking, being active, that type of thing. So he started to have right anterior knee pain, which is in the front of the knee, after he did a 22-mile trail run, and then 2 days later he did a 50-mile bike ride. Some of the aggravating factors, things that bother him, are running, biking. He's having a hard time with sit to stand. So whenever his knee gets to approximately 45 degrees, so if he's squatting down to get something, he has trouble going up and down stairs. Downstairs is worse. And he describes his pain as sharp, but sometimes aching and stiff when he's trying to move. He didn't really do anything about the knee pain at first when he had it. He just kind of said, oh, I'm going to rest, and I'm sure it'll get better. So I'm not going to think about it. And he just kind of continued on his way, being active, and nothing really happened. So he just kept having this pain. He went to see a chiropractor. He saw them for a few visits, somewhere around 5 visits, and he didn't feel like anything really helped. So then he went to see a couple of physicians and got an MRI. The MRI noted that he had a possible tendinopathy in the right knee. This was also around the time that his left knee started hurting, which was really interesting. So he went to PT for 5 months, and he did a ton of exercises for his glutes and his core, but again, nothing seemed to change. So he is super frustrated, and he feels like he's seen, 4 providers already. He doesn't really have a plan. No one's told him what to expect. And he's only really done exercises, some hands-on, some scraping, some stretching, a little bit of mobility, but that's it. So that's the person that is coming into your clinic, Sara, Dr. Raiser. So I would love for you to start and tell me what you would do.
I have so much to say to that because I feel like these last couple of weeks I've been talking to people that I always see patients when they've seen 4 to 5 other providers. So I'm never the first one seeing them, and there's so much to sift through, including I did 3 courses of physical therapy. Well, what did you do? Who did you work with? What is their expertise? And did you do the exercises? Because that's an important question too, right? So I actually really enjoy these cases because it's really doing a lot of detective work and figuring out what they've done so far. Of course, in the back of my mind as a physician, I'm thinking, well, do we need to potentially consider getting MRI? And I don't necessarily want to jump on that unless we really feel like we've tried all the things. But oftentimes, if I'm seeing a patient at this point, usually they're like, I want the MRI. I want to figure out, is there something else going on that I need to address that's beyond biomechanics? So that may potentially be my role. But certainly
Sorry. He did have an MRI, and it showed a little bit of right patellar tendinopathy, but he didn't have it on the left.
Got it. It was the left side it started on, yeah?
Started on the right and then moved
on
to
the
the
right.
left.
Okay,
yep.
got it.
Just so you know, because would you get another MRI because it's been several months?
Probably not. And, the tendinopathy, I'd probably throw an ultrasound on it and see what I see from the ultrasound perspective as well. And I'm assuming that's probably patellar tendinopathy.
Yeah, but the MRI said that it was very slight. So,
got it. Okay.
And that they weren't worried about it was the quote. So this is actually somebody that I talked to.
So a super thorough exam, super important. I'm sure Kate is going to do the same thing. So really, I'm looking for, are there any big red flags that we need to, hone into a little bit more? Or is this all biomechanics? Certainly when I see patellar tendinopathy, the tendinopathy in and of itself can cause problems, but oftentimes I'm thinking a step further of, well, what caused the tendinopathy? And usually there's something rotational that's happening at the knee. There's some instability probably that's happening up at the hip, but then you can also have a setup for instability at the knee joint. You could have hypermobility. There's a lot of different components that could contribute to that type of scenario. So with that tidbit, what I might be thinking about is, do we need to try any interventions? Do we need to do shockwave therapy or PRP or different treatments to specifically treat that tendon? So I do really thorough exam to figure out where exactly is their pain, and is it actually the tendon, or is it really more kind of patellar tracking or patellofemoral type pain?
Great. And then Kelsey, if you had a patient like this who has been dealing with this for a long time, so they're a collegiate athlete, they're frustrated, they're doing all these things on their own to try to make themselves feel better, but they feel really lost, and it's been probably a year in total. What would you do when you spoke to this person?
Yeah, the thing that I latched onto when you were presenting the case was the change in lifestyle between being a college athlete versus now starting our first job, even sitting down more, depending on the program that they were an athlete at. That might have been a fully supported nutrition program, meaning all of their meals were accounted for. They didn't have to think about it. What is his meal prep skills like now that he's out in the real world and not going to dining halls, and having coaches and trainers and everybody involved in his care as a student athlete reminding him to eat and it being convenient, free or affordable, and all of these things, juggling a new responsibility of having a career. And then also the change in activity you talked about, he was kind of weekend warrioring, and that a 22-mile long run, we don't do that in college, or for the most part, not that I know of. And so that's a little bit different when we think about, even if his mileage shook out to be the same by the end of the week, engaging in kind of being a weekend warrior changes your recovery, and it changes your nutrition needs during activity and your hydration needs. So if he's not following a proper during long run nutrition protocol and a proper hydration plan, that can certainly impact the muscles and the tendons. I always say dehydration. I think of beef jerky. And then those muscles and tendons around like supporting joints are going to be can get more irritated. So the hydration for being out on your bike for 3 hours is going to look a lot different than being out on a long run as, a 5K or 10K runner. So I would be really curious about how is he supporting his new lifestyle? Is he meal prepping? He's still really active. So how are we eating, and what is the quality like now that you have less support coming from a collegiate program? And have we adapted some things? And that would be the big picture. We could always dive into tendon specific health, but I think that that would be the change in lifestyle, I think would be the really interesting piece for me.
Awesome. That was actually one of the most interesting pieces for me as well. He said that his second, the knee pain on the left side started to come up 5 months ago when we spoke, and it was right when he started his job. So one of the things I asked him right away about was stress, as I often do, right? Stress is stress, like we always talk about. And I asked him, have you managed your stress? And he just looked at me. And he said, you know what? I think you're right. Maybe I am stressed. And so it was really cool because it was a light bulb moment that might be part of the puzzle. It's obviously not the whole thing, right? So what I also wanted to know about was, have you had a gait analysis, which is something Sara would definitely ask and maybe do herself, and I would do myself. I asked him if he'd ever been fit for a bike, and if he'd had a bike fit, because that's, something I was trained in. I don't do it, but I was trained in it, so I understood it. And I was thinking about, your foot is fixed on a pedal. And when you're on a bike, and it's really the only time your foot is fixed while you're moving above it. And when we run, it's the opposite, right? And so it's just a different way that we move our body and how our knee tracks. And so I was thinking about that piece of it. So top of my list would be making sure someone's looking at you on your bike. And I would have that person, if they weren't in my clinic, I would have them video themselves front, side, and back on the bike from your head to your toe. So I could see what was happening at your foot and your hips and your back. Also like your position on the bike with your arms. And then I would also do a gait analysis and obviously functional movement, like what's happening in a squat. Is his knee tracking, or what's happening there? Does he have the strength to support it? And I would want to rule out things like the back as well, because just because of that referral pattern from either L1 to L3, depending, or even 4, depending on which part, facet, disc, nerve, that kind of thing, in that area. So those are things that I would also be thinking about. And I would ask about shoes. Has he changed his shoes recently? Has he not changed them? Sometimes people keep their shoes for, thousands of miles, and they're essentially falling apart, especially if you don't have money to buy a new pair.
I was about to say that time of your life. Yeah.
Yeah. So, those are things that I would definitely start thinking about. And then I would also ask, like you said, Sara, about treatment, right? So, what has he done in treatment in PT? Have they touched that? Have they actually put their hands on his knee? Have they looked at his pelvis? Have they looked at his foot? Because the knee is trapped between the foot and the pelvis. And so you kind of have to treat all of those things in order to support the knee. So those were kind of like all the things. I felt like this case, when I heard this gentleman talking about it, I was just like, in my mind, my brain was going crazy because I'm like, there are all these things we need to look at.
So bike fit was one of the big things I was thinking about as well. And, I think I actually have the exact same sentiment. I always find it very overwhelming because when I go into that room, I know it's a negotiation and I have to figure out what they want to do, because you can work through this pain to some extent, right? And sometimes that can be a little bit of a catch-22 because it's so hard to rein people in sometimes, and they just keep doing things that keep aggravating. Same thing with tendinopathies. I find that people can sometimes work through it just enough that you keep kind of egging it on. And a lot of the conversations I have are, you have to fix the biomechanics before the pain can then go away. So you work through a little bit of discomfort, you address the biomechanics, and then as those improve, then you have this delayed response of having pain improve too. And sometimes it can be really tough to make sure that that is happening appropriately, and that your pain's not getting worse, or the pain you're having with PT is not good. Another reason why I always tell patients they need to tell their PT if they have pain. So I, always ask questions about them being sore the next day, and I'm like, did you tell your PT? Because it's just so important that they're giving that feedback to be able to make progress.
Yeah. And you know what I found, and I find often, because like both of you, I get people who have seen 4, 5, 6 other people before they get to see us. And they're so frustrated that they don't actually know if they'd want like this one clear answer. And when you've had pain or an injury for a really long time, it's hard to have one clear answer or diagnosis, because by the time you've gotten to us, other things have happened. So maybe the tendon has already healed and it's a biomechanical issue now, or a strength issue somewhere else. Maybe it's 2 or 3 things happening. So it is really hard. I find it's really hard in those types of cases to really get the person to understand, like, hey, we know this is where you really want to be, but it's going to take time, and that's a frustrating thing, but we can do this together, and let's start with one thing and then move forward. Yeah. What about you, Kelsey?
I don't know, it's so hard for me to hear you guys talk about cases and not, like, as someone that's moving out of injury, directly think about how when you are injured, you are so vulnerable and do want one clear answer. Also, you're over it and you're so tired of being in pain. So that part and willingness to be in pain has dwindled. So there's a lot of things. And one of the most healing things when I was in Boston was like you kind of palpating my hamstring, and you're like, you know what? That's not the worst thing in the world, because then, even though you can't tell someone exactly what's going on, just thinking about it and kind of streamlining what the answer might be and what to focus on definitely helps an athlete.
Yeah, I think so. And I think giving direction and a plan to the best of our ability.
Yes, with the information you have.
Right. And then also understanding there's some trial and error, which again is really, really hard if you don't have trust in the system, because you've already seen a bunch of people. Being willing to do some trial and error with a new provider can be so scary. Do you see that, Sara?
Absolutely. I've actually had a couple of patients recently who have kind of non-specific pain, and they've had a workup and everything has looked okay. And so they're super frustrated. And then we start uncovering some concerns about eating and nutrition. And, then we start thinking, maybe this actually is kind of a REDS case. Even though it certainly didn't initially present that way. I actually had a patient who kind of blindsided me at the very end of the conversation, like had all this pent up, all this stuff she wanted to tell me. And I hadn't hit the right question yet for it to all come out. And then she told me everything at the very end. I was like, oh, okay. Well, now I know what to do. Here we go. But it's kind of crazy, because I was kind of getting to the point of like, well, we just give this thing more time. And she's like, but I'm not eating enough. And I was like, oh, okay. Well, we can address this. But I think sometimes that can be a really tough thing to, I find that sometimes the nutrition factor can be hard for people to connect, especially after they've been through something frustrating for 5 months, 6 months, a year. And so sometimes that requires some rapport, and I can't have that conversation the first time I meet them, or I may lose them. So it's interesting talking about this right now, because I realize how much finagling that has to be done. I've really got to feel them out and figure out where are they in that headspace, and how can I best help them in that moment, because it's just not straightforward. You may gather from all this, I don't see my patients for 10 minutes at a time. It takes a little bit longer to have these conversations, for sure.
Yeah.
Need more Dr. Reisers. But yes, with nutrition, a lot of times when there's a lot of pride involved with nutrition, I think. And even when someone comes to me and they have at that point been honest about that they want at least some sort of help with their nutrition, right? By the time they have an appointment with me, still kind of acknowledging that they're not quite eating enough can be really, really difficult. And even when I explain the concept of REDS, sometimes the first time they hear it, they don't identify with that's what they're dealing with.
Yeah. And I think with someone like the athlete that we're talking about now, I'm kind of going to bring it back around to this athlete, this 26-year-old male athlete that has probably patellar femoral knee pain. I think that with this particular athlete, the approach has to be very careful, and you have to make sure that they understand that what they've been through and how brave they are to have even reached out to you and started this again after having seen so many people, and then not overwhelming them with too much information at first, and saying, okay, this is where you are. I'm going to meet you there. Let's get through this one thing. And when we get through this one thing, we'll go to the next thing. And then we'll build our goals together so that you can reach your next goal. But along the way, you have to undo a lot of things that they've told themselves, all these different stories that they've told themselves and other people have told them, and all the advice they've gotten from other people and the internet and Chat GPT and their own history of what they did with their coach. If they're a former collegiate coach or a former collegiate athlete, oftentimes they'll go back to what they were doing in a time where they felt good and try to emulate that. But then that's not what they really need to be doing anymore.
Yeah. You bring up a good point about isolating variables. Research shows, I think this is worth mentioning in all of our scopes. Yeah. Research shows the more interventions you give, the less compliance there is. And so it's like top should be like 3.
Yeah.
And then after that, it's like, even if you just give them 1, the compliance of that 1 is so much stronger than 3. And so that's kind of how I structure my programs. And it's hard because people want all of the information. With me, they want to know what they're going to put in their mouths from the time they wake up, from the time they go to bed. But I'm more focused on, I'd rather you be consistent with these 1 to 3 things for a little bit until we add more.
Completely. I mean, I usually say, okay, sometimes my homework is, okay, why don't you just start writing down how you're feeling? Or I might say, which is a killer for a physical therapist to say, or how about we start meditating? Or how about I give you this one drill for your arm swing, or this one exercise that I think is going to help to start. See how you do with that, and then let's move on. And people hate that, but then they're so happy when it starts to work.
Yeah, they build awareness first if you are meditating and that kind of thing.
Yeah. Anything else you want to say, Sarah?
I'm just thinking how jealous I am. You guys see your patients more often. So I can usually swing 2 to 3 weeks. And so I'm still trying to cram in so much information. And my catch is I try to write as much stuff down as I can and try to kind of give them the plan. But yeah, I'm always trying to capture their attention, like, please come back because I've got more. But I've got to figure out how to give them the information that will entice them to come back to see me. And, I've got colleagues who will stress fracture, actually even patellofemoral pain, you see them 2 to 3 months apart, right? Go do PT, and after your whole course of PT, come back and see me. But especially if I start picking up on other things that I think that we can work on, outside of just sending folks to PT, that, I'll try to put in hey, we'll get the MRI, I'll see you back in 3 weeks. And so we'll review the MRI, and then we can touch on some other things like your stress. How are you handling stress, and how is your sleep going, and those types of things, and asking some more specific questions. So I do try to find ways to see patients more often because I do find there's so much value in it, and developing the rapport and having conversations you otherwise wouldn't. Well,
I do want to point out, though, with you, Sarah, what you do a really good job with is communicating with the people that you've sent them to. And so I think that helps. I mean, for me, I often tell, if you send me a patient, when we're going through things, I'll say, hey, I talked to Dr. Raiser about this, and connect it back so that they understand that we are all talking, or we are having conversations, and that you're still involved in their care, even though you may not be seeing them every single day. And same thing with Kelsey. Hey, I talked to Kelsey because I really wanted to understand this, and I think that is valuable, and because then they understand that you're still an integral part of the whole process when it's you, and when it's a physician that does that, and not every physician does that, and some don't need to, but you do, and I think that helps your patients quite a bit.
Yeah. And I think with the other interdisciplinary squad that you work with, you train us too, that when we're working with other providers, we're kind of expecting that level of care from the other provider. The athlete that I was texting you to about today, of course, she was asking, she has a stress fracture, but I was asking about bone density, so slew of injuries. And she was like, well, I don't want to make an appointment because it's this date and my foot's going to feel better by then. I'm like, this is a case. This is a case. But you guys have taught me to expect for my athletes to have a team for cases, not just for one injury. Or
Yeah. Being able to put it all together so they don't have to come back for something else, right?
yeah.
Cool. All right, guys. Well, I think that is a wrap for this particular case. Well, thank you everybody for joining us tonight and going through these different cases with us. If you have a case that you want us to talk about and kind of work through, we would love to hear from you. Our email is runcasemiles@gmail.com. And we will check that email and we will look through the cases. And if we see some there, we will eventually they'll make them on the pod or make it to the podcast. So please reach out. You can also reach out to us with any questions. And if we get questions, we'll try to address them on the next podcast as well. So thank you again for joining us. And we can't wait to see you again.